Okay. Once again, I would like to welcome everybody on this platform. And my name is pharmacist Victor Obuna, and I work for Superior Pharmaceuticals. And you will agree with me that postoperative pain remains a critical determinant of orthopedic recoveries. Poor pain control can also delay mobilization, prolong hospital stays, and also negatively affect patient outcomes. And again, with the increasing concerns about opioid dependence, effective evidence-based multimodal analgesia has become essential in modern orthopedic practice. And in line with that, today we'll be looking at the topic optimizing evidence-based PANAC. And you just we have Dr. Ajibola. Can anybody hear me? Can't hear anything.
Couldn't hear you for a while. I just heard you again when you said, "Can anyone hear me?"
You might have to repeat yourself.
Okay. I said my name is. Let me start afresh. My name is Pharmacist Victor Obuna, and I work for Superior Pharmaceuticals, the organizers of this webinar. And like I said earlier, postoperative pain remains a critical determinant of orthopedics recovery. And poor pain control can delay mobilization as well as a prolonged hospital stay, and also negatively affect patient outcomes. So with increasing concerns about opioid dependence, effective evidence-based multimodal analgesia has become essential in modern orthopedic practice. And with that, today we will be looking at the topic, optimizing postoperative pain management in orthopedics using evidence-based strategies with PANAC. PANAC is actually a brand of Ketorolac from the tables of Superior Pharmaceuticals. And to do justice to this topic will be Dr. Ajibola Oladiran. Dr. Ajibola Oladiran is a consultant orthopedic and trauma surgeon, and also a senior lecturer at the Department of Surgery, College of Medicine, University of Ibadan. He's also head of orthopedic and trauma and surgery department in UCH. So let's welcome Dr. Ajibola Oladiran. You are welcome, sir.
Thank you very much. Good afternoon, everyone. Thank you for the introduction. So let me proceed to share my screen so that we can start right away. Can you see my screen?
Yeah, we can.
Okay, so we'll be talking about acute pain management using PANAC, has been said previously, and I'm sure practically everyone listening to this presentation has being in pain at some point or the other. It's one of the most common reasons why people present to the hospital. It's one of the things that keeps us busy as doctors, and it manifests in various ways. We know the pain is defined as perception of tissue damage, and it could actually be physical, psychological, emotional, whatever the cause. Pain is pain, but we're going to be talking about physical post-operative pain today rather than the other forms of pain. And pain, when it's not adequately treated, could delay recovery, slow down the patient's mobilization. Pain actually increases the physiological response to trauma and the stress response in the patient. And a patient who is in pain will not be eager to go home. So the patient ends up spending longer in the hospital, hospital costs are increased, and then time away from work for the patient as well as time away from work for the caregivers end up adding significantly to the cost. Now, for pain to be effectively managed, we need to have a combination of several factors. First and foremost, the methods we're using to manage the pain have to be safe. The analgesic has to be of very good efficacy, and side effects have to be minimal. And now we aim to achieve that by using multimodal approaches, both physical.
Thank you, Father, to hear all the glory. In my for in Jesus Christ's name we are giving thanks.
Sorry, please, can you mute your mic?
Current clinical practice emphasizes multimodal approaches that aim to combine analgesics that work through different pathways in order to be able to use the minimum possible dose so that if a synergistic effect between the different analgesics achieves adequate analgesia while side effects are minimized because doses are reduced. So moderate to severe pain could be caused from post-surgical pain, trauma, fractures, acute musculoskeletal injuries. An otherwise fit, active young person has gone out on the weekend to play ball with his friends. He gets an injury, sprains a knee, twists an ankle. Colic is also causes very severe pain, whether it's renal or gallstones, and various acute inflammatory conditions are also common causes of pain. Now, when pain is poorly controlled, as has been mentioned, prolonged hospital stay delays recovery and increases the patient's stress response with tachycardia, hypertension, increased metabolic rate, and secretion of cytokines that tend to have other adverse effects on the patient's metabolism. It's important for patients to be comfortable and for people to be satisfied with the outcome of the care they have come to receive. So if the primary complaint is pain, then we need to do something about the pain, both the pain of the primary presentation as well as pain from our intervention. Functional recovery is delayed if the patient is in pain, because even if a fracture is healing or a wound is healing, but the pain is not subsiding, then the patient isn't feeling or getting better because the pain, which is the primary reason why they have presented, is still there. And then overall clinical outcomes are rated much better when pain control is adequate. So we know that injury from either surgery, trauma, burns, or other inflammatory triggers tend to release inflammatory mediators, which could be prostaglandins, bradykinins, or cytokines into the body. And this serve to sensitize peripheral receptors so that the body is more sensitive to stimuli, and this amplify the pain signals at the part of the injury. Now, this normally is a way to sensitize the body that something is wrong and give us a stimulus that we need to withdraw to protect ourselves. It's part of the mechanism for survival of the species. However, when this persists or the pain is severe, it begins to have detrimental effects, and prolonged increased prostaglandin levels now lead to hyperalgesia, where the sensation of pain is increased out of proportion to the stimulus, there's edema and inflammation. The edema tends to cause swelling of the tissue and if this persists over a long period of time, it results in fibrosis, stiffness, and impaired function. Inflammation also leads to for severe pain, but there are significant limitations. One of the most worrisome is respiratory depression and sedation that are caused with strong opioids because they're centrally acting. Nausea, vomiting, and constipation are common side effects of opioids. And then there's a very real risk of dependence, addiction, and misuse, especially when they're used over a long period of time or whether when they're used in high doses. Now, other adverse effects may not be delayed mobilization and recovery because the patient is getting something that causes sedation. So it's safe to keep the patient in the hospital to monitor the respiratory depression and the sedation. Monitoring requirements are increased and hospital stay is prolonged. I'm an orthopedic and trauma surgeon, as I was introduced earlier, and really, there really is no point having done a procedure under regional anesthesia. Patient is awake throughout the procedure, but post-operatively, we now need to give opioids that now cause sedation. So the essence of the regional anesthesia is almost completely defeated. So when opioids can be avoided, it's best for our practice. And then in case, at times when we do day case surgery where the patient is meant to go home the same day, we want to avoid opioids as much as possible. So in many clinical settings, the use of opioids is limited by safety concerns, as I've mentioned. Regulatory restrictions are a major worry. We know how difficult it is to get tramadol in Nigeria because of the strict regulations. And then availability and monitoring challenges, especially for patients who are sensitive, who have severe reactions, or who have respiratory depression. Those increase the needs for monitoring, the needs for care, and end up increasing the cost and the complication profile of the cases. And as surgeons, we don't want to have complications, whether they are related to the surgery directly or not. So current pain management strategies now focus on opioid-sparing approaches and use of non-opioid analgesics whenever appropriate. Non-steroidal anti-inflammatories play a very crucial role in the management of pain, particularly when inflammation is a major driver. The opioid-sparing benefit has been well documented both in surgical and emergency settings as well as non-surgical settings. And opioids provide analgesic and anti-inflammatory effects by inhibiting prostaglandin synthesis. So they reduce the pain intensity, decrease inflammatory edema, and overall increase the functional recovery. Now, NSAIDs demonstrates opioid-sparing effect so that the dose of the opioid required, if the patient still requires opioids, is significantly reduced, and thus the patient has... Could we mute our mics, please? Thank you.
He went to hospital.
Short-term use of non-steroidal anti-inflammatories in acute pain is very effective, and they are generally very well tolerated, especially when they are appropriately selected. For the purposes of this lecture, we will be focusing on Ketorolac trometamine, which is marketed as Panache and is a preferred choice for moderate to severe postoperative pain, delivering fast and potent analgesia with opioid-sparing effects for safer and much more effective recovery. It has been shown to have analgesic efficacy comparable to opioids and is commonly used in emergency departments and trauma settings, and it offers the ability to reduce the need for opioid administration and minimization of opioid side effects. Essentially, it's not a selective cyclooxygenase inhibitor. It inhibits both the COX-1 and COX-2 enzymes and reduces the constitutional and inducible pathways, reducing the synthesis of prostaglandins, thromboxane, and prostacyclin, and also inhibits the peripheral NMDA receptor activation so that the nociceptors are not it reduces the stimulation of nociceptors and thus the analgesic effect is increased. Ketorolac trometamine has a relatively rapid onset of action. When administered intramuscularly, the onset of action is 10 to 20 minutes. When administered intravenously, is 10 to 15 minutes. Peak analgesia that is achieved in the 75th to 150th minute. So that's in a little over an hour to 2.5 hours is the period where peak analgesia is achieved. Peak plasma concentrations are achieved in 30 to 60 minutes, whether it's given oral or IM. Bioavailability is very good with the intramuscular and route of administration with bioavailability up to and above 80%. It's markedly bound to protein. Over 99% of it is bound to protein. So this helps to increase its duration of action, and it's widely distributed throughout the body. Its metabolism is essentially via glucuronidation and oxidation. So it has an elimination half-life of 4 to 6 hours. Now, it's excreted mostly as conjugated metabolites in the urine, which accounts for 90%, about 90% of its excretion, and 10% of it is excreted in feces. The implication of this, as we will mention later, is that in the event of renal impairments, dose adjustments is required, but minimal adjustment in dose is required in renal impairments. Because of the reduced decline in renal impairments with age, clearance is reduced in the elderly and the half-life is prolonged, so we may want to consider modifying their doses. A few studies have been done to assess the effectiveness of Ketorolac, and Gora and Appa et al. Compared opioid analgesics to Ketorolac in spine and joint procedures. And it was found that patients in the Ketorolac group reached milestones like their first bowel movements, commencement of oral intake, and unassisted ambulation much sooner than those in opioids. This is expected as constipation, nausea, and vomiting is some of the major side effects of opioids. So it will stand to reason that oral intake will be delayed in somebody who has significant nausea or vomiting, and the constipation side effects of opioids will delay the first bowel movements following surgery. Postoperative stay was also much less in those with Ketorolac, as the use of opioids tended to increase the need for monitoring. And it was found that despite the higher cost of Ketorolac compared to the steroid that was being used in this study, the overall cost of care was 32% lower on account of the reduction in hospital stay. And those who were in the opioid group also had more significant central nervous system complications. A comparison between Nefopam and Ketorolac as adjuvant analgesics for postoperative patient-controlled anesthesia. This was a randomized double-blind prospective study that used 80 patients. This used a combination of fentanyl with Ketorolac compared to a combination of fentanyl with Nefopam. Analgesic effects were comparable, and pain scores at rest and during deep breathing were similar, but postoperative nausea and vomiting was much higher in those who had Nefopam compared to those who had Ketorolac. As expected, Ketorolac did much better than paracetamol in patients undergoing laparoscopic surgery. So other studies with the key findings, lumbar spine meta-analysis done in 2024 showed that Ketorolac significantly reduced pain and opioid use postoperatively. The kidney donation protocol found Ketorolac to be safe and effective, and Ketorolac was found to be non-inferior to oxycodone for post-endoscopy pain. However, it's also important to note that oxycodone is an opioid that has constipation as a major side effect. This is a table that directly compares Ketorolac with diclofenac and paracetamol. It's important to keep in mind that Ketorolac has a high GI risk, so the use needs to be kept to 5 days or less. No medication is perfect, so once these safety ideals are adhered to, Ketorolac is a very safe and efficacious medication.
Unity of purpose in efficiency to achieve better patient care, better patient outcomes, and satisfaction better.
So this table compares Ketorolac with nefopam and pentazocine. Nausea and constipation, as we know, is a significant side effect of opioids. Nefopam has low to moderate nausea and vomiting, while the major worry with Ketorolac is ulcers and bleeding. Outside of this, Ketorolac did significantly better than nefopam and pentazocine. So the indications for Ketorolac tromethamine are moderate to severe acute pain, postoperative pain, musculoskeletal trauma, dental surgeries, and renal colic, amongst numerous others. Dosing is 30 milligrams every 6 hours for the average size adults. Maximum daily dose is 120 milligrams, maximum of 120 milligrams per day for not more than 5 days. As was mentioned earlier, in elderly patients with renal impairments, or in people with a body weight of less than 50 kg, we reduce the dose by 50%, so the maximum daily dose would be 60 milligrams per day when administered either intravenously or intramuscularly. Contraindications are advanced renal disease, active gastrointestinal bleeding, peptic ulcer disease, or a previous history. And Ketorolac tromethamine is not recommended for labor and delivery. So to summarize, Ketorolac delivers opioid level pain relief. It's a cyclooxygenase inhibitor, a non-selective cyclooxygenase inhibitor that dampens inflammation, pain, and swelling. It can be given intramuscularly or intravenously to patients who are not yet taken by mouth and require fast relief. It has a relatively long duration of action, and it lends itself very conveniently to opioid-sparing strategies in the management of our patients. Thank you very much for listening.
I'd like to thank Dr. Oladiran for a well-delivered lecture. Thank you so much. I really appreciate it.
My pleasure.
Then I would also know that some people would like to ask some questions. So you can take questions now. Yeah, if anybody in the audience has anything to ask based on what he just delivered. So that
hello, sir.
And also
hello. Transfer.
Okay, we transfer to operator.
Okay, Dr. Clement Akot, are you have a question?
Hello.
Yeah, you can go
Hello,
ahead.
good afternoon. We can hear you.
Can you hear me?
Yes, we can. Dr. Clement, I'll call your mic is muted. We can't hear you.
Yeah. Dr. Clement, if you can hear us, I think you are muted. Your mic is muted. You can unmute so they can speak. Okay, while we wait for Clement to unmute, if any other person has any question, take that. Question time. Question time.
Hello, Leonie, your hand is up. I think you can unmute and ask your question.
Oh, good afternoon, sir.
Good afternoon,
Thank you
sir.
very much for the wonderful presentation of that pancake. My basic question is this. If you know that the pentazocine has become an injection of addiction to HBSS patients. So does this pancake too, we have this addictive effects? So to the extent that we have been able to see that when I saw that pancake, I realized that, well, this is beautiful. Now that even the HBSS patient knows pentazocine very well. So I think when this thing comes around, so I want to find out, is there any addictive effect to such extent that the patient will be so curious to be having it? Thank you very much.
Thank you very much. Panache is a non-steroidal anti-inflammatory that does not have addictive properties. So addiction is not a concern with Panache. However, the choice to abuse medications is an individual choice. People abuse paracetamol, even though paracetamol is not addictive. So we need to differentiate between abuse and addiction. But to answer your question directly, no, Panache does not carry a risk of addiction, unlike opioids. So your worries with pentazocine do not apply to Panache. On your chat, Kenneth, please go ahead. For those of us who may be in a place where the background noise makes it difficult for us to speak, we may drop our questions in the chat. I've been checking the chat and there are no questions in the chat yet. If there are questions in the chat, I will proceed to answer them immediately.
Hello, Chief. Good afternoon.
Good afternoon.
Yeah, thank you. Sorry, I wanted to ask, there's this, your remark, the last statement you made about Panache, talking about usage of it in those with history of ulcer. Is it only those with previous history or those with active ulcer. Because to know most patients, one way or the other in this place, have one previous history or the other. Is it that bad that even with previous history, we cannot use it?
So I will answer that question very cautiously. I do not advise patients who have a previous history of ulcer to use Panac unless they have. No, let me put it this way. I do not advise Panac to be used for patients with a. Can we mute our mics, please? Thank you. I will not advise the use of Panac in patients who have had a previous history of ulcer unless the benefits outweigh the risks. So if one needs to use Panac in somebody who has a history of ulcer, then we need to pay extra attention to the onset of epigastric pain and monitor the passage of blood in stools, either acute bleeding or passage of melena. But personally, I would recommend that Panac be avoided in people that have a recent history of ulcer. Definitely, Panac should not be used in people who have acute bleeding or have symptoms of gastritis ongoing. Chris Chima.
Sorry, again, in the comparison with those stuff, it seems or you want to link up with corporate stuff about.
I can barely hear you.
I'm saying that in comparison of those stuff, you didn't mention, you didn't take cognizance of the stuff. Or as in, you want to link with the corporate stuff about the most of the stuff in relation to pain and.
Could you type your question, please? Your voice isn't clear. I'm sorry. Charles Ediani, I hope I'm pronouncing your name well. Yes, you raised a very good point. The issue with the bleeding with gastric ulcer is not peculiar to Panac. It's something that applies to all non-steroidal anti-inflammatories, except for the selective COX-2 inhibitors.
And we do a lot of procedures. Yes, now. No, the volume is there. The volume, all we have to do is just start compartmentalizing those things. This one is arthroplasty, this one is
TDUGOK, are you asking a question?
trauma.
Chris Chima, your hand is raised. Please go ahead. Okay, Dr. Clement Akko, I will leave the comment about the cost to pharmacist Victor. Thank you.
Okay. Yeah, thank you for that question. Talking about the cost, Panac is actually very costly. Hello? Hello, can you hear me?
Yes, we can hear you. It was Chris Chima that was asking a question earlier. The hand has been raised for a couple of minutes. Chris Chima, please go ahead. Pharmacist Victor has paused for you to ask your question. Please go ahead. Hello? Chris Chima, are you there? Pharmacist Victor, I think you should go ahead.
Okay, talking about the cost, it's actually very cost effective when compared to the likes of pentazocine and then maybe the opioids. An ampoule of Panac, one ampoule of Panac comparable to maybe say pentazocine, you can actually get Panac from retail shops at an amount of let's between 550 to 600 naira from retail shops. So when compared to pentazocine that you can get for over 1,000 naira and thereabouts. So you can see that Panac is actually very cost effective when compared to all these other painkillers like opioids or pentazocine and the likes. So I don't know if I've been able to answer that your question, sir.
Hello? Hello?
Hello?
Yeah, can I speak, please? I've been...
Yeah, go ahead. Go ahead, sir.
Okay, I've had your rep here in Enugu. I work in Enugu, actually. I've had your rep make delivery of these products to me or to a facility where I cover. I'm actually a pain manager, specifically. I'm an anesthetist. I've had him make this delivery of these products, basically. One is, from my findings, the message about the company identity, products, and all that is not loud, actually. And there were some reservations in terms of the cost. You say you can acquire an ample of this for 600. Yet there are still some opioid products that you can apply, even acquire rather, even pentazocine that you can get for as low as 600, same. You understand? But the truth is, the message of Panac is just more basically targeted at reducing opioid effects postoperatively. And for our surgeries right here in orthopedic, we need we use more of opioids, basically. We'll use more of opioids. And I think I've spoken to him sometime to get to the pharmacy unit. So the price too is part of their limitation. The price is part of their limitation from my finding. Duration of action, it's quite a short acting drug from the time I used it. So I don't know if it could be improved on. And there are no specific gradings as per journals as per milligram per kilogram body weight of your products. I think somebody asked a question on that while I was trying to get them to use these drugs. You understand that kind of thing? So I think we should have more people talk about your products, have more reps represent the product, because Mr. Victor actually is doing a whole lot of job here in Enugu. I think he's the only rep I know from this facility. Then some other person check your products, know people's complaints. That's all for now.
All right, Doc, I would like to really appreciate your contributions, and at least you've also showed that you've talked out of experience, out of somebody who has related with the products. So we really appreciate your contributions, and I've also taken note of what you said, and we'll get back to you on this.
Professor Notsich, sir. Please go ahead.
Hello, everyone. Hello, Dr. Oladiran. How are you?
Good afternoon, sir.
How are you, my dear brother? Thanks so much for an excellent presentation.
Good to hear from you, sir.
Thank you. Thank you for the excellent presentation and the efficient way you fielded the questions. I'm just curious about this product that seems to have such an emphasized 5-day limit of use, and I would like to know why. Is it because of the issue about peptic ulceration, or is there something else, some other reason why the 5-day limit is emphasized so much?
Thank you very much, sir. So majorly, the reason for the limitation is because beyond 5 days, the risk of peptic ulceration and bleeding has been found to be significant. And then because of the renal clearance, and that's a second reason. And for acute pain, we typically find that within 5 days, the pain would have been dealt with significantly, such that the analgesic needs can be stepped down. So something that is not, maybe not as potent as Ketorolac. So it's a sacrifice of potency for the risks. So if we keep it at 5 days, then the risks are not an issue, either for the GI complications or for the renal clearance issues. And to say something about one of the numerous lovely points that Chris Chima made earlier, that Dr. Chima made earlier, more and more we are trying to move away from opioids, even in orthopedics, where the need for analgesia is significant. Like I mentioned earlier, where I do more and more of my cases as day case. So for a patient that is going home the same day of surgery, I do my cases early in the morning. Patient is on his way home by this time of the day. As much as possible, I don't want to send the patient home on opioid analgesics. So if I've done the procedure as regional early in the morning, spinal as one-off, patient can sit up, patient can ambulate, and the patient is going home, then I want to avoid opioids as much as possible. And the drug as efficacious as Panache allows me to do that significantly, and then the patient can go home on non-opioid analgesics.
Thank you very much. That's great. Thank you.
My pleasure, sir. Yes, there's a question in the chat. Permit me to pronounce just the Solomon. I don't want to mispronounce your name. I'm sorry. The question is, can Panache be effectively incorporated into a multimodal analgesia approach? And how can Ketorolac be optimally used alongside opioids or regional anesthesia to enhance pain control while minimizing opioid requirements? I will answer that by saying yes, Panache can be used safely with the multimodal analgesia. One of the studies I mentioned during my presentation was actually comparing use of Ketorolac in multimodal analgesia as opposed to Nefopam. That was one of the examples I cited in my presentation. As per the details of how it can be used, I will not go into that in this presentation. I will leave that to people like Dr. Chris Chima, who is a pain specialist and analgesics, and those who are directly managing the patient, so that we do not go beyond the limits of this presentation. But to answer your question, yes, Ketorolac definitely lends itself to very effectively and safely to use in multimodal analgesia. Thank you.
Okay, are there more questions? Can we have more questions? If there's anything that needs clarification, so that it can be clarified here before we wrap up. More questions?
Hi, I do have a question. Can you hear me? I have a question.
Please go ahead with your question.
Please.
My question is: do you recommend use of Ketorolac for arthritis pain?
For what?
Arthritis, joint pain, arthritis pain, rheumatic pain.
To answer very bluntly, no, I do not.
Yeah, because it's a skeletal
Those
muscle.
conditions you mentioned are chronic conditions.
Yes.
There is nothing to be gained by using a drug meant for acute pain that should be used for less than 5 days to treat a chronic condition, unless it is being used to treat an acute flare of the pain, in which case it will be used only for a short period of time, and then the continuation of the management will now be with other medications. But as the sole analgesic for a chronic condition like arthritis or rheumatoid, no.
Sorry, 1 minute. Well, good day, house, please. As a sole analgesic for acute chronic conditions, but I feel usually in pain management, there is usually a structure or a ladder kind of that we use in managing chronic pain. Just like you said, the short flare of such pains, you could actually use it with other adjuvants, maybe even...
My point exactly, that's what I said.
Yeah, you could actually still even mix it out with paracetamol too. So, yeah, smaller stuff like paracetamol could increase its efficacy and reduce. I've done that before in St. Gian, actually. It was for a hysterectomy. I gave the panache with paracetamol. So you can still add some adjuvants to increase its efficacy and reduce its side effects.
Yeah, so yes, certainly, like I said, it lends itself very well to multimodal drug therapy. So for an acute pain, and like somebody just said, sickle cell crisis is usually an acute flare So yes, you can use it for the immediate pain crisis in combination with other medications that can be used for a longer period of time if need be. And then after the initial flare of the first couple of days, you can discontinue the panache and continue with a more long-term pain management plan.
Another very sensitive question, please. Is it safe to be used in neuralgial pains like in migraine, headache?
I'm sorry, I'm not sure. I'm an orthopedic surgeon. Neuralgia, migraine is completely out of my area of specialty, so I will defer to pharmacist Victor to answer that.
Okay.
Hello.
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 Yeah. Good day, sir.
Yes, sir.
Well, Victor,
Hello.
go ahead.
Right. Thank you for
yes.
Okay, thank you, sir, for the wonderful presentation. My question is, the essence of this presentation is how to encourage the usage of panache in a post-operative pain. But based on recent challenges, you see that most patients always come down with, most patients always have this history of GI issues. So, and that's actually a main factor limiting the use of Panac. So, in your own experience or field of knowledge, what should be the best approach, maybe in using this Panac for patients that need such a pain management control? Because
Hello? Okay, I can't hear you anymore. I'm not sure if you are still speaking or if it's an issue with the network, but I
Myself?
hope you can hear my response. So to answer your question, yes, GI issues are relatively common, because a lot of people abuse non-steroidal anti-inflammatories, and unfortunately, advertisements on TV will say, advertising over-the-counter drugs will say after a hard day's work, take this or that. I don't want to mention names. The truth of it is, after a hard day's work, you need to rest, not take analgesics. But unfortunately, because of the efficacy of those adverts, people abuse a lot of analgesics, and people living with chronic pain abuse analgesics. So patients present with history of with GI conditions as a result of prolonged use of non-steroidal anti-inflammatories. That is one challenge. But be that as it may, for a patient who will be managing for postoperative pain, again, I'm an orthopedic surgeon. Unless it's an emergency, a patient who has an active GI bleed will not be scheduled for a major elective orthopedic surgery. You will sort out the GI bleed first. So at the time it's coming for surgery, it usually is safe for him to have Panac for the short period of 2 or 3 days that he will need immediate post-operative analgesia with Panac. Now, I will say this with a lot of caution, but while the risks are documented and significant, I have not had any issue of GI bleed from giving a patient Ketorolac. And I've been using the molecule Ketorolac for more than 15 years. I have not had a patient bleed from use of Ketorolac. So when the choices are made safely and cautiously, then the risks can be mitigated at best or avoided altogether.
Okay, thank you, Dr. Oladiran. To answer the question whether it can actually be used for the management of migraine, the answer is yes. You can actually use Panac, Ketorolac, to actually manage, but it is often used off-label for severe acute migraine when other treatments actually fails. You can actually use migraine, and it actually can be given IV or IM. It works. I don't know if I've been able to answer that part of the question that was asked earlier.
I believe you've been able to. So there's a question asked here by Solomon. In line with using Panac in sickle cell disease, an orthopedic postoperative patient with sickle cell disease, where both bleeding risk and vaso-occlusive pain are concerns, how do you balance the use of Ketorolac given its effect on platelet function? So one of the things with sickle cell patient postoperatively is one of the major problems is pain, because pain in itself may trigger a sickling crisis. But post-operatively, Ketorolac is safe. It just means that we will not be giving it in conjunction with an anticoagulant, because using a non-steroidal anti-inflammatory together with an anticoagulant significantly risks bleeding, not just GI bleeding, but spontaneous hemorrhage, petechial hemorrhages, and all of that. So the risk of bleeding are significantly less if the surgery has been properly done. In most cases, has been meticulous, tissue has been handled carefully, dead space has been closed. If all of that has been taken care of, then Ketorolac is safe for post-operative pain, even in C class.
Okay, I don't know if I've taken all the questions, and is there any other question before we wrap up? Okay, I can see there's a question there on the chat saying, Doc, is it safe? So let me pull it up.
Is it safe to mix panache and opioids
Is it
together
safe
and
to mix
administer
panache and
to a
opioids together
patient at
to a
once?
patient at once?
I wouldn't mix them together. I avoid mixing different medications together in the same syringe. Whether it is safe to mix together for patient-controlled analgesia, pharmacist Victor, please educate us.
Okay, you mean mixing them on the same syringe? No, you can. It's not pharmaceutically. It's not advisable.
I didn't think so either.
Yeah, it's not. You can't do that.
Pharmacist Victor, I will let you take the next question as well. It's from Jerry Obi. Is panache safe in pediatrics?
Panache is actually safe, yes. It is. But it also has to do with body. Again, is something that actually when you also need a risk in terms of the benefits, because also the GI effects.
Okay, so it seems that is all of the questions in the chat.
Oh, okay. Well, in the absence of any other, to thank Dr. Oladiran for a well-delivered presentation, and on behalf of Superior Commercials, we would like to also say a big thank you for everybody who actually participated in this webinar. We're actually very grateful, and is another hand up? Let me see.
No, that was a reaction. It was an applause.
Okay. So we'd like to say to everybody. We really appreciate this. And we also want to also employ you. Presidents. We really appreciate it.
Okay. Thank you very much for the opportunity. Thank you, everybody, for listening. Have a wonderful evening.
Thank you. Thank
Thank you.